Ma'am, you have only few seconds left. I'll start the session.
So, good evening, all. Yeah, welcome to yet another session of breast imaging in ICRI Radiology Resident Teaching Program 2025. So, before starting the session, I am sending you a good wishes for Independence Day. So, today we have two speakers who will talk about on the ultrasound breast, Dr. Upasana from the AIMS Patna and Dr. Poonam Bajaj from Gurgaon. So, to moderate today's session, we have Dr. Malvika Gulati with us. She is a consultant in the Apollo Research Center, and she is an ex-fellow of women's imaging from PGI Chandigarh. So, over to you, Malvika. Please introduce our speakers.
Thank you, ma'am. And good evening to the speakers and our attendees. So we'll kickstart today's session, which is on breast ultrasound. And for the first talk, I invite Dr. Upasana Sinha. Ma'am is an additional professor in All India Institute, Patna. And ma'am has had her training from the prestigious AIMS Delhi and PGI Chandigarh. And currently, she has a special interest in breast imaging and interventions related to breast and women's imaging, including gynecology and obstetric imaging, and also musculoskeletal imaging. She has various national and international publications and also is the section editor in the Indian Journal of Breast Imaging to her accolades. And we will have ma'am's talk today. So, ma'am, I invite you for delivering the first talk on breast ultrasound.
Thank you, Malvika, for the kind introduction. And at the outset, I would like to thank SRI team and Tulika ma'am for giving me this opportunity. I will share my screen. It can be seen now?
Yes, ma'am.
Yes, ma'am.
Okay, then I will start. I will be talking on the basics of breast ultrasound. It is a technique, advances, and indications. And for residents, I think they should know more of technique rather than advances. And of course, they should know the indications. So I will be focusing more on the technique, how you should do a proper ultrasound breast. Because ultrasound breast doesn't it is not similar to like you do ultrasound abdomen and all, because ultrasound breast needs lots of optimization of the imaging and lots of adjustment you have to do while scanning so that you don't misinterpret the lesions. So a brief introduction. The breast ultrasound was started long back in 1950, and for many years it was limited to, or many years it was used mainly for different settings, cystic lesions from solid lesions. And gradually they found out that it's a very good tool for characterization of mass, it's benign and malignant. And finally in 2003, ACR comes with the ACR Barrett's ultrasound lexicon, where they describe all the descriptors and lexicon for the ultrasound. And in the last 2 decades, with many new advances in the breast ultrasound, now it has become a standard of care diagnostic imaging modality for breast imaging. And while ultrasound technology continues to improve, the quality of ultrasound image remains largely operator dependent. So whoever is doing the breast ultrasound must be aware of appropriate scanner settings and should know how to optimize the scanning methodology so that it improve your diagnostic performance and you doesn't misinterpret the ultrasound findings. So my main objective is to in today's session will be to discuss the technique of the breast ultrasound, including what probes should be used, what positions should be used, and how do we optimize the image settings, and what are the few advances in breast ultrasound, and what in the end I will let you know what are the indications of breast ultrasound. So now, whenever you start a breast ultrasound, the first thing that you have to do is to choose a correct probe or transducer. Now, ACR practice guideline has said that breast ultrasound should be performed with a high resolution, real-time, linear array, broad bandwidth transducer operating at a center frequency of at least 12 megahertz, but preferably higher. So what does it mean? That you have to use linear transducer and it should have at least 12 megahertz of its frequency. For many decades, previously started people were mainly using 7 to 8 megahertz. But as you are aware, the breast tissue is hardly 3 to 5 centimeter and very superficial structure. And as you know, high frequency transducers are good for imaging a superficial structure. So when you are using a high frequency transducer, it gives better spatial resolution, but it decreases depth. But in case of breast, it doesn't matter because most of the breasts are generally 3 to 5 centimeters. However, some breasts can be larger. In that case, you can use low frequency transducer and it will increase your penetration, but it will decrease your spatial resolution. So one thing about a good point about today's transducer is that it is broad bandwidth. So it has a range of frequencies. Thus, it can both has a high frequency transducer as well as low frequency transducer. But at least 12 megahertz would be included in the probe. Now next, how do we position? Now, the main aim of your doing a breast ultrasound that you should scan the entire breast, because you know the breast, your main aim is to rule out malignancy, and malignancy starts with a small lesion. So you need to flatten out breast against the chest wall for scanning. So how will you do it? You make the patient lie supine with the arms raised above the head, as you can see in this picture. So when the patient lies supine and the arms is raised above the head, your medial part of the breast flattens out, and now you can nicely scan it. Now, what about the lateral part of the breast? In a small breast, you can continue in the supine position, but when the breast is large, your breast will force along the lateral side, and it won't be proper to do the scanning on the supine. So what you do ultrasound in supine oblique. That is, you elevate the side with the base under the shoulder so that your lateral side flattens out, and you can nicely see the lateral part of the breast. But sometimes breasts are so large that even the supine oblique, your breast will hang towards the lateral side. So in that case, you can make the patient to turn more. That is, you can do in the decubitus view and you can see the far lateral part of the breast. And while doing breast ultrasound, you should apply a gentle uniform pressure and try to scan the entire breast and then leave a part of any breast. And one thing, sometimes breasts are larger, then what you can do increase transducer pressure for better penetration. Or else you can do a little bit of lower frequency transducer, like about 8 to 9 megahertz frequency probe. So this was about the probe selection and the position of the patient. Now, how do you scan? What is the scanning technique? There are two types of scanning technique: grid scanning pattern and radial scanning pattern. So in the grid scanning pattern, very simple. You move your probe either up to down in rows, and you one thing you should be careful is that while you're moving from top to down and down to up, you should have overlapping the area that you are scanning, so you don't miss in any area. So it's very simple. You go down, up, and scan the entire breast. So this is a longitudinal scanning of the breast. In the transverse scanning of the breast, you move the probe from lateral to medial, then again medial to lateral, again in overlapping pattern, so that you don't miss any part of the breast parenchyma. So it's very simple. Another method is radial scanning pattern. So in this, if you think this is a probe, this is the footprint of the probe. In the radial scanning, you will go all around the breast like this. Then you will go a little bit outer. Again, you have to overlap the first round with the second round. Then again, you go around like this. So you are scanning in the radial pattern or a clockwise pattern, as you can see here. So then what is anti-radial pattern? So this was the radial. When you make the probe 90 degree to this radial scan like this, and then you move from out to in in overlapping fashion. This is called anti-radial scanning pattern. I prefer to do anti-radial scanning pattern because it's easy to move from out to in, rather than moving in the radial pattern. And most of the people in the radial scan they move on to the radial scan once they start with longitudinal transverse or anti-radial. And if they see some dilated ducts or some lesions in the direction of this inner to periphery, then they go for the radial scan plane. So So it depends on the operator, whichever they find easier, they can do. Some people scan pattern, while I prefer to do anti-radial scanning. Now, before going to proper scan setting, what all settings to do while doing scanning, I would like to tell you about the anatomy of the breast that we see on the ultrasound. So the breast will lie between the skin and the pectoralis muscle. So on ultrasound, the breast is divided into 3 layers: pre-mammary zone, which consists of skin, subcutaneous tissue, and this echogenic lines here, proper ligament, mammary zone, and this is the main zone which contains the fibroglandular tissue of the breast. And all the echogenic areas that you are seeing, these are mainly fibrous connective tissue, and all the hypoechoic area are mixtures of your fat lobules as well as ductal and periductal glandular tissue of the breast. And then you have third layer, that is the retromammary zone, which consists of retromammary fat and the pectoral muscle. Now coming to what all you should do for image optimization, we'll go one by one. There are lots of way of optimizing the image while doing the breast ultrasound. The first thing that you have to do is to see for the depth. You have to adjust the depth to ensure that the entire breast is imaged. That means from skin to pectoral muscle, and usually it's about 4 to 5 centimeter for every side breast. And SAR guidelines is there. While when you start scanning breast, when you don't know about the lesion, you're just surveying or screening the breast, you should cover the entire depth of the breast, but pleura and lung should not be visualized. You can see this first image. Although the entire breast is seen, I've also included the pleura and the lung. This is not ideal thing because your overall image has become now minimized. And you can see in this image where I've included from skin to pectoral muscle, but there is no pleura and lung. So this is the ideal way of starting the initial surveying of the breast. Once you find lesion, you can adjust FOV to depth selected areas. So first depth, we move from skin to pectoral muscle. The second thing that you have to adjust is about the grayscale gain. What does this gain mean? Gain refers to the overall brightness of the image. The goal in breast ultrasound should be to keep the background fat lobules at medium gray. So you can see the fat lobule best in the subcutaneous tissue. So its color, or you can say that it gain should be adjusted in such a way that it appears as a medium gray. It is similar to liver grayness. So what you can do, you set the dynamic setting between 55 to 70 decimal, or you adjust your gain in such a way that subcutaneous fat has the same gray level as the intragranular fat. Nowadays we have time gain compensation where they automatically adjust the gain, but in case automatic adjustment is not there, you can do manually so that you adjust in such a way there is a uniform brightness throughout the depth of the breast. And it is necessary for one more reason because whatever you describe in the breast ultrasound, if you find any lesion, you describe it hypoechoic, isoechoic, all these are done in relation to the subcutaneous fat. So unless and until your gain is correct, you will be wrongly describing a mass echogenicity on the ultrasound. So what happens if you pass gain?
Can you press hide in your screen, which is coming next to stop sharing? Yeah, thank you.
So what happens if gain is too high? When the gain is too high, the fat lobules, like you see here, will appear bright gray or white. So a fluid lesion, like this is a proper gain setting, you can see there is a subcutaneous fat is of average gray. So this is proper setting, you can see there is cyst. But what happens when you have increased the gain? You see the subcutaneous fat lobules have become white, and your fluid lesions is not so anechoic as compared to this lesion. So you, in case of small lesion, you might misinterpret a cystic lesion as solid mass. And similarly, vice versa, when you put the gain too low, the fat lobules appear dark gray or black, and you might misinterpret a small solid mass as cystic lesion. So be careful about the gain of the lesion. So therefore depth and gain. Now you have to adjust the focus. If you while doing the ultrasound, you will see that there is one arrow. Most of the time it's arrow or sometimes linear bar like. That is that indicates the focus of the transducer. Where is the focus of the transducer base? Actually, what happens at the focus is that your transducer ultrasound where it's coming from the transducers are narrowest at that point, and at that point it is the highest resolution area at that level of the focal zone in the probe. So focal zone must be set at the level of the diagnostic area or lesion. So when you are doing a surveying the breast, the focal zone should be placed at the level of the mammary zone. When you're doing it in the breast ultrasound, you're just starting if you don't know the lesion. So in that time you place your focal zone at the level of mammary zone because it is that place where you're going to get the most of the breast lesions. And once you identify the lesion, you position the focal zone at or just below the lesion, so it will optimize the resolution of the lesion and its posterior features. This is an example. You can see the center. I have put the focal zone at the level of the lesion, and so nicely you can see the margin of the lesion. And in the first, I have shifted the focal zone much below the level of the lesion. And you can see that the lesion margin has become blurred and the lesion is somewhat hazy. Same thing here. I have shifted the focal zone much high above the lesion, and again you can see the margin or overall lesion is not so sharp as in this case where we have placed the focal zone at the level of the lesion. So once you get the lesion, you put the focus at the site of the lesion, and if you don't have, you have not seen any lesion yet, and you're just scanning the breast, and you put the focus at the mammary zone of the breast. In zoom and magnification, once you get any lesion, you see its margin on magnification or after zooming it, because it will give you a better understanding of the margin. Although on zooming you can see this is without zoom and this is with zoom or magnification. Although on zooming your overall resolution is reduced, but you can nicely see the margin. See here the margin is not so well delineated, but here you can see the indistinct margin, the irregular margin. Although overall resolution of the image decreases on magnification. The next important thing in breast ultrasound is Doppler setting. This is very important because many times we come across in clinical scenario we get a small lesions, we don't know it's a complicated cyst or solid lesion. In that case, your doctor comes to your help. Sometimes when you have a dilated ductal, you have interductal contents, you don't know whether it's lesions or actual lesions. In that case, also your doctor will come to help. So, but doctor will be of help only when you have done its setting, proper setting. Otherwise, you will get a wrong interpretation of the vascular flow. Also, in case of breast cancer, there is angiogenesis and the vascular flow, there is very slow flow in the vessels. So, you have to adjust it to detect this slow flow. So, what all you can do while doing ultrasound after detecting a lesion, if you're putting a color Doppler, don't press the lesion. So, this is the first image. I have pressed a lot, and you can see I can't see any vascular flow. Once I release the pressure, I can see the flow. So, you use light transducer pressure over the lesions, and you adjust the box size to the lesion. This will also improve your detection of color flow. Reduce the scale. So, in this case, you see the scale over here is 5 cm per second, and over here it is 3 cm per second. So, on decreasing the scale, your flow will increase. You will better appreciate the color flow. Can you use power Doppler? Power Doppler, you must be knowing it has no directional flow. It will just tell you the slow flow. So power Doppler is better than color Doppler to detect the slow flow. One more thing you can do, you can increase the gain of your machine setting. It will also show the color flow better. Now, one new advantage that has come in the Doppler setting is the microvascular imaging technique, MV flow. It's not present in most of the machines. It's some high-end software and it's costly. And it has the capability of detecting even the slow flow that can't be detected by power Doppler, and it gives a very nice image of new angiogenesis of your tumor. So if you have these features in your machine, start using this for your breast ultrasound. Now coming to field of view. In the starting, we had seen the depth. Now we will see the field of view, the width of the lesion of the scanning area. So ultrasound has a limited field of view. That means its field of view is limited to the probe footprint. So this is the probe, you can see only this much. You can't see beyond that. So what you can do, especially when you have a large lesions, you want to take the entire lesion size. There are three ways that you can do. One is dual screen. That you split your monitor display into two, the dual display, and you put your lesion side to side without overlapping, and you can measure the entire length. That is a dual screen, but this is very good. You might not be able to accurately align the lesions. Next thing that you can use trapezoidal. In trapezoidal, your base becomes widened, then your transducer probe, and thus it increases the area of scanning both at a depth as well as the lateral aspect. And once again, you can measure the size of the lesion if it's larger than your footprint of the probe. And one of the advances that nowadays it is almost present in all the machines is panoramic view, which is also called extended field of view scanning. In this, you have to do nothing, just same probe that you are using, you put on the panoramic view switch button, and you move the probe, translation movement of the probe over the skin, over the lesion, without moving much. You go in a straight line along over the lesion, and the software will continuously compare the position and will create a large 2D image without any loss in terms of spatial resolution, and you can see in this. So these are large lesions which you could not have been able to see even with the dual screen and panoramic, but panoramic view you can nicely see. And what is the advantage of this panoramic view? It displays and measure large lesions and display the spatial relationship and the distance between the lesion and some anatomical landmarks such as the nipple. You can measure distance from the nipple. You can also see the relations between the multiple lesions, so you can tell whether it is multicentric or multifocal, which may not be possible with the dual screen or trapezoidal imaging method. So panoramic view is very useful view. If you have that, use this also. Coming to harmonic imaging, this is also available in all the machine, but once to be aware about this to use it in the breast ultrasound. So as a sound wave travels to tissue, it distorts it gets distorted and it gets different resonant frequencies in the multiple of 2, 3, 4, 5. So when you put on harmonic imaging, the second harmonic frequency of the sound wave is used on the harmonic setting to create the image, and the other harmonic frequencies are filtered out. So what does it do? Because you filtered out of other multiples of frequencies, you have improved spatial resolution, and your grayscale contrast between the fatty tissue and breast lesions improves. It decreases artificial echoes in cystic structures, and it accentuates the posterior acoustic feature of lesions. So all this will help you in the better characterization of the lesions. How? When you have any cystic lesion and you see some content within it, but you are not sure whether it is a complicated solid lesion or just entire cystic, you put on harmonic. You will see a drastic change in the image. See, this is a without harmonic image. You can see some isotopic areas are here, which are not sure whether it is a solid or just artificial. And when you put on harmonic, you can see all these have disappeared, and so nicely now I can say that it is an entirely cystic lesion with no solid component. One more use of harmonic is that it makes isotopic nodules appear darker. Many times in the young breast ultrasound, you will get some lobulated fat, which you're not aware, you're not sure whether it's just a fat lobules or small fibrinoma. You put on the harmonic. If it's a fat lobules, it will stay as isoechoic. If it's a real nodules, it will appear more hypoechoic. But one of the disadvantages of using harmonic imaging is there is increased shadowing in dense breast. As you can see here, there was no shadowing over here, but here the shadowing has increased. So although it improves the spatial resolution, but there is some increased posterior shadowing in case of dense breast. But since we are also using conventional techniques, so we have to interpret finally combining all the findings. So one of the advantages is spatial compounding. It is not commonly available in all the machines. Some additional software have to be taken for spatial compounding. Usually when you are doing a routine ultrasound, you are using normal probe, ultrasound waves go in the linear directions. But in spatial compounding, the emission as well as reception of sound waves at different angles of insolation, resulting in improved lesion boundaries and perspicuity. So what is advantage of this is that lesion is being seen from multiple directions. So multiple ultrasound images are formed from multiple angles, and finally one image is formed. And it is called spatial compounding. So although you can better see the edge characteristic, like see this is without spatial compounding, and this is after putting on the spatial compounding, you can see the margins visibility has improved much as compared to this one. But one disadvantage of using spatial compounding is that posterior acoustic feature is lost. So when you're using for cystic lesion or malignant lesion posterior shadowing, they will be decreased or lost. So once again, we don't have to use any software in isolation. We have to also consider the finding that is in it without using this software. So combining the both findings, we can come to a nice conclusion and we can overcome this disadvantage of spatial compounding. So this was about the setting of the machine, but now I will tell you about a few areas of the breast that needs particular technique to see properly, because just scanning in a normal like we scan breast of the breast may not be adequate to see lesions in these regions. One of the regions is rectoareolar region. When you just put a probe on the nipple areolar complex, you will see the posterior shadowing. This is due to the crevices and irregular surface of the areola where the air gets trapped and your probe is not uniformly touching the entire area of scanning. So how you can overcome this? You put a thick pad of gel like this. I have put a lot of gel in this, and you can see the nice nipple and rectoareolar region seen, because on putting lots of gel, it reduces the air trapped in the crevices and decreases the artifacts. Other techniques that you can use in for rectoareolar region is you press on the transducer, you press from this side or that side, you see better. You angulate your probe, you can also move the patient. All this will improve the visibility of the region in the rectoareolar region. So whenever you are scanning rectoareolar region, just don't stop just seeing from the front, because you might miss the lesions in the rectoareolar region. And the Stavros has described several maneuvers to improve visualization of rectoareolar lesions. And these techniques are mainly based on angulation of the transducer in order to generate an ultrasound beam perpendicular to long axis of the duct. And these are the three techniques that have been described as Stavros. Let's see each one of them. So in the first image, you can see that the probe is put directly flat on the nipple region, and what you get lots of shadowing in the rectoareolar region. So you can apply one of these three techniques to improve the visualization. The first one is peripheral compression technique. It is the one end of the probe is kept on the nipple, and you give pressure on the probe from the lateral end. So what happens? It improves the visualization of your peripheral part of the rectoareolar ducts. Then other is two-handed compression technique. Here you put the probe on the one side, and with the other hand you compress the breast so that it somewhat gets elevated, and you put the one end of the probe on the nipple, and with the other end you give a pressure. So this improves the visualization of your central part of the rectoareolar ducts. With the peripheral compression, you can better see the peripheral part of the rectoareolar ducts, and with the two-handed compression technique, you can better see the central part of the rectoareolar ducts. And then other technique is roll nipple technique. In this, what we do with the finger, we put the nipple over the finger with the help of the probe. So nipple gets rolled over the finger, and you then press with the transducer. And the advantage of this technique is that you can see the dilated duct even within the nipple. So you can try all these maneuvers whenever you see a dilated duct in the rectoareolar region. It will help you in the detection of any intraductal mass in the rectoareolar region. Then again, you have a problem when the lesion is very superficial. It is either in the dermal or hypodermal lesion. So this is a normal scanning. I just put the probe, and you can see the skin is so thin. So if you have any lesion over here, you might miss it. So when you put lots of gel, you can nicely see the thick skin. And you can measure it. You can't measure over here. You can measure it. You know the normal thickness of the skin is 2 mm, except in the areolar region and in the inframammary fold. So you can nicely see the anterior dermal line, posterior dermal line. So you put lots of gel if you are suspecting superficial lesions, or while scanning you are seeing that some lesions are there in the skin or subcutaneous tissue. So this is an article where they have described how to differentiate between the dermal and the subdermal lesions in the breast. So in case of dermal lesions, this is an anterior dermal line, as I have shown you here. This is an anterior dermal line. This is a posterior dermal line. So the lesions may vary in the dermals or in the subcutaneous dermal junction. They have 90-degree acute angle with dermal line. So when the lesion is intradermal or in the junction of it, it will make an acute angle with the dermal line, or you will get a close sign of hypertrophic skin illuminating around the margins. So when you get a close sign and acute angle, you know it's a dermal lesion. However, a subcutaneous lesion will make an acute angle with the posterior dermal line. Most of the dermal lesions are considered benign, usually like usually infected sebaceous, small pustules, inflammatory lesions. Also, hypodermal layers, subcutaneous lesions are usually benign, but rarely superficial breast cancer can arise from the superficial or displaced terminal rectalobular duct. So this is example of a skin lesion. See, I put lots of jelly, so I can nicely see. If you not put jelly, you might have missed this lesion, and you can see it's totally intradermal, nicely anterior dermal line and the posterior dermal line intact. So this is intradermal superficial infected sebaceous cyst. Also, when you put lots of jelly, you might be able to see in the punctum in case of sebaceous cyst. And this is a subcutaneous lesion, however, is not contacting with the dermal line. The breast ultrasound examination is not complete without examining the axilla. So for axilla again, position is same. You have to put the patient supine oblique and put her hand above the head, so your axilla area gets staged and your probe will be nicely in contact with the skin. Again, you have to use high frequency transducer. And one of the main indications for doing axillary ultrasound in case of breast, if you're doing breast ultrasound, is for the assessment of axillary lymph node. As you're well aware that the detection of axillary lymph node, any suspicious lymph node, would change the staging, diagnosis, and prognosis of the patient in the case of carcinoma breast. And the morphology of the lymph node is the best appreciated ultrasound rather than mammography and MRI. So ultrasound is actually the investigation of choice to evaluate axilla. So what all axillary nodes you have to see? In axillary nodes, the most commonly that we see, you will see the level 1, 2, and 3. And how it's divided in level 1, 2, 3 is depending on the relation to the pectoralis minor muscle. So any lymph node that is infralateral to the lateral margin of the pectoralis minor is level 1. Lymph node posterior to the pectoralis minor muscle is level 2. In fact, the rotator lymph node that lies between the pectoralis minor and major also come under level 2 lymph nodes. And any lymph nodes which is superomedial to the upper margin of the pectoralis minor, or we can say infraclavicular nodes, are level 3 lymph nodes. One should also be aware of the intramammary nodes, as these nodes are seen within the breast parenchyma, and there is a misconception that the intramammary nodes are always seen in the upper part of the body. It can be seen even in the inner part, in fact, it can be seen in any part of the breast. So you should also look for intramammary nodes, because intramammary nodes are also considered under the axillary nodes. Although, however, most commonly is in the upper part of the content. This is a nice article published in the Radiographic in 2021, where they describe the various morphology that can be seen in the axillary ultrasound, and they classified into type 1 to type 6. In the type 1, they are telling you there will be imperceptible cortex, and the hilum will be intact, so this will be benign. In type 2, your cortex is still thin, but it's thicker than the type 1, but it's less than 3 mm. The hilum is still intact. This is also 100% benign. So type 1 and type 2, if you see type 1 and type 2, this is definitely benign. In type 3, there is diffuse hypoechoic cortex thickening, which is more than 3 mm, and this is diffuse. So this can be seen also in reactive lymph nodes, and the hilum is intact. So actually, this is indeterminate, but most of the time, this is benign, and rarely it can be malignant. In the type 4, due to deposition of tumor cells, as you know, the tumor gets deposited from the in the subcapsular region first. There will be bumpiness or lobulation of the cortex. It will also indent into your hilum, but your hilum is still intact. So this is suspicious. And then we have type 5 lymph nodes where there is a focal hypoechoic cortical lobulation with displaced hilum. This is also very suspicious. And finally, we have type 6 where the lymph node is completely replaced by a mass with absent or replaced hilum. So type 1 and type 2 are benign. And from type 2 to type 6, as you move across this morphology, your likelihood of malignancy gradually increases. And type 6 node with absent or replaced hilum with a high probability of being malignant, about 60 to 97% of likelihood of malignancy is there. However, there are also other features that have been described in various literature. Even ACR guidelines has indicated about this. Size, there is no definite criteria to tell, depending on the size, to differentiate the benign and malignant lymph nodes. Shape, it is said that when the long to short axis ratio of the lymph node is less than 2, it is suspicious. When it has become round and your long to short axis is less than 2, it is suspicious lymph node. Cortical thickening more than 3 mm, I've already told you, whether it's a diffuse or focal lobulated. The margin is also a very important feature to indicate a metastatic nodes. So indistinct margin, irregular margin, spirited margin are obvious feature of metastatic nodes. Then hilar compression displacement, I've already shown the type 1 to 6. In the type 6 where you have total displacement of the hilum, and you don't see even a small part of the hilum is totally displaced. Takes a high risk ratio of metastatic nodes. And one more feature to describe is that presence of subcapsular flow also favors malignant lymph node rather than a hilar flow. It will normally get in the normal lymph nodes. Normally, for a long time, even today, most of the breast ultrasounds, when you do, you tend to look only for the axillary lymph nodes and intramammary lymph nodes. We don't see supraclavicular internal mammary nodes. But the updated by ACR is going to complete the 6th edition. They have mentioned that they have included even supraclavicular nodes and internal mammary nodes also in the breast ultrasound lexicon. So, if possible, especially for getting level 3 lymph nodes, you should also look for the supraclavicular and the internal mammary lymph nodes. So, supraclavicular lymph nodes, you see just about the cavity. And in case of internal mammary nodes, you know internal mammary nodes lies along the internal mammary vessels that is in the parasternal region from sacral to intercostal spaces. So, you put your probe along the parasternal region and you put Doppler to identify the internal mammary nodes vessels, and anything in large addition to it will be the internal mammary nodes. But you be aware that you can get internal mammary nodes also in the normal person. And one thing I would like to tell you is that most of the breast drainage of the lymphatic circles in the axillary nodes only. With almost 90% of the lymph node drainage lymphatic circles in the lymph nodes. With some deeper parts and the middle parts, it is hardly 10% that drains into the internal mammary lymph nodes. Now, regarding the advances in the breast ultrasound, there are the advances, but elastography has been used since many decades, and among these, only elastography is the one that is commonly being used by many breast radiologists nowadays, whereas all these are not available, very limited availability. And regarding contrast ultrasonogram, it is not very much important because in this you need to have an IV line, you have to give intravenous contrast, and after giving contrast, you see the real-time muscular pattern of the lesions, and it is found that it doesn't give any definitive diagnosis. So whatever the findings, you have to do biopsy and morphology suspicious. So it has not gained much importance in the breast mask evaluation. So I will deal mainly with elastography because of limited time, because this is the one that we commonly use nowadays. So what is elastography? Ultrasound elastography is a non-invasive technique that assesses tissue deformity by providing information on the elasticity. And what is elasticity? Elasticity is nothing but the stiffness of the mass and the surrounding tissue. And this is based on the conception that the cancers and surrounding tissue are expected to be hard, whereas benign lesions are expected to be softer. There are two types of elastography: strain elastography and the serial elastography. In the strain elastography, tissue deformation is measured under manual compression of the mass. That is, we put a light pressure on the probe to induce a deformation in the lesion. And this can be measured in two ways: qualitative or semi-quantitative. Qualitative means it's just you have to see the color and tell it's hard or soft. So in this case, you can see this is a well-defined hypoechoic lesion. On color coding, this is green. So different vendors have different color coding. So you should not, it's not like the green will be soft and blue will be hard. You have to see the what is the color coding in your machine. So according to this machine, this is diffusely green and this is soft. Where this is a malignant mass, you can see morphology itself, it's malignant, and this is a diffusely blue on color. So this is just a color coded qualitative way of saying that the lesion is hard or soft. The other semi-quantitative method is strain method. In this, what we do after taking the elastograph image, we put ROI on the mass and adjacent normal parenchyma, and then we calculate the strain ratio. So actually, the ratio of the stiffness of the mass with that of adjacent normal parenchyma or fat, and higher the strain ratio, more the probability that the mass is malignant. Then we have second type, strain elastography. We have shear wave elastography. In this is quantitative method where it gives you the measurement, it gives the accurate measurement of your stiffness of the mass in kilopascal or velocity in a meter per second. So it measures the shear wave speed. In this, when you're doing the shear wave elastography, you don't put pressure on the probe. Automatically from the ultrasound waves goes into the lesion and it measures the shear wave speed to the lesion. So these two are two different techniques. This is point shear wave. In point shear wave, we measure the shear wave only from a point in the lesion. Where this is 2D shear wave. The entire lesion is color coded, and then we take multiple ROI, and then finally we take the mean of this measurements, which will give you in the kilopascals. We can see here shear wave velocity measured in the kilopascal. So various studies have given very well cutoff, no exact cutoff, but one of the study they've given it you can take a cutoff 80 kilopascal. So the lesion which has stiffness more than 80 kilopascal more likely to be malignant. But there is no standard cutoff for this assessment of the lesion. So why do we need to do elastography? This is because ultrasound has low specificity, leading to unnecessary biopsies. So you add elastography to your morphological feature, it will improve the sensitivity, and you may avoid biopsy in certain cases. And ACR has recommended to use this elastography for bias 3 and 4A lesions. So whenever you see bias 3 lesion, you put elastogram. If it's hard or suspicious on elastogram, you upgrade it to bias 4A. If safe and benign, you can put it on the follow-up, or you can downgrade it to bias 2. And if you have bias 4A lesions like well circumcised but some irregularity and on the margin, and on elastogram it appears to be hard and suspicious, you can upgrade it to bias 4B. And if it's soft or benign, you can downgrade it to bias 3. So right now, the ACR recommended to use it only for bias 3 and 4A, and not for deciding the mass in benign and malignant in the initial stage. You must see the morphological features. And if it's bias 3 and 4A, then you apply the elastogram. But what is the limitation of elastography? It is operator dependent. So like when you do strain elastography, it depends how much pressure you're putting. If you're putting lots of pressure, it might so increase strain ratio. It is not good for small and deep lesions. Because in deep lesions, your vein might not reach up to date. So it's not good for small lesion. And then again, since it measures the stiffness or hardness of the lesion, there are also variable benign lesions which are hard, as well as malignant lesions like which are soft, like your fibrosis sclerotic fibrinoma. It will appear hard. Your like mucinous carcinoma, triple negative carcinoma, it can appear soft on elastogram. So elastography should not override the more predictive morphological features of malignancy. Just few lines about automated breast ultrasound. This is a 3D volume imaging technique with multiple reconstruction. This image taken from the net. You can see this is a ABS machine, which is a large transducer, which is about 15 centimeter, which acquires full breast volume from skin to chest wall, and data is stored, which can be viewed later. And like CT images, you can make the sagittal, axial, cornel, and nicely you can see the relations of the multi-center multifocal. You can nicely see all the relations of the lesions. And European Society of Breast Imaging has recommended that you can use handheld ultrasound or 3D ABS as a supplemental screening modality following a negative mammogram in women of average or intermediate risk with dense breast. It means they have recommended that we can use this ABS even for the screening of the patients. But although it's done automatically, means it's done, you take this time, but during review you have to give more time because you have to see each and every image. So although it's like can be done even by a non-radiologist, you can just put this transducer and immediately acquired, so your time is saved here. But here you have to give time to see all the sections, like you see the CT images. Now AI in breast ultrasound, now the AI has been used in all the imaging from head to toe, and so it has been also being used in the breast ultrasound also. As you know, the basic fundamental about AI is that it uses deep learning algorithms which enable automatic detection, quantification, and characterization of breast lesions. It is also used to predict treatment response in locally advanced breast cancer. And CAD, that is computer diagnosis. And this AI can be used as a second reader because it improves accuracy in ultrasound and contrasted ultrasound. It helps in aligning region safe and malignancy risk using bias or other descriptors. And this system can be offline, like you can use in the PCBs, or it's integrated into the scanners. Like we also have Samsung machine, and we have this software. Only thing you have to do is you have to focus on the lesion, you put cursor over there, and it will automatically, and you put on the S-detect, it will automatically measure the size of the lesion. It will give you all the morphological features of the lesion, and it comes as S-detect in Samsung, but it's semi-automatic. It doesn't give you time features. Sometimes some of the this remains vacant, and we have to fill it. But improvements are still going on. Now coming to my last topic of today's lecture is indication where all you should do this breast ultrasound. And these indications which you can hear from the ACR guidelines parameter, which was updated in 2021. So according to that, you need to do breast ultrasound for evaluation and characterization of palpable mass, breast with signs and symptoms, whether it's nipple discharge, nostalgia, or redness, whatever signs and symptoms, you can evaluate with ultrasound. In evaluation of abnormalities detected on mammography or MRI, if you know there is second ultrasound that we do in case of any finding deficiency on MRI, so that perhaps it can be done easily on ultrasound, or any lesion detected in other imaging modality like even CT, PET CT. So you see this is a lesion detected on the mammogram. This is an ambulance view. You can see a lesion with obscured margin, so you don't know whether it's benign or malignant. So on ultrasound you can see this is a cyst, so you know it's a virus 2 lesions. This is another example again, well circumscribed high density mass in the retroviral region, round or oval shaped. But on ultrasound you see it's a solid cystic mass with increased vascularity. So this is a suspicious bias 4 lesion. One thing that you should be aware that the breast ultrasound is not limited to female. It's also done in the male. And for male, in the male, one of the most common lesion that we detect on our main hair is gynecomastia. And ultrasound is a very good tool for diagnosing gynecomastia. So this was a 26-year-old male who came with the uterine enlargement of the breast. And clinically they were suspecting it was malignant because the obvious palpable lump was there. So see on ultrasound you can nicely see there is a retroviral hypoechoic area with dendritic patterns emerging with a surrounding breast parenchyma. So and on elasto it was benign. So ultrasound is also a good tool for imaging a male breast, especially in case of gynecomastia. Other indication is the initial imaging evaluation of the palpable breast masses in patients under 30 years of age who are not at high risk for development of breast cancer and in lactating and pregnant women. So you must be aware that whenever you get a woman, not only under 30 years, also under 40 years, if she's lactating and pregnant women, you don't go for mammogram state, you do first ultrasound. So ultrasound is imaging of choice in younger women, in pregnant and lactating women. So ultrasound can also be used for guidance for breast biopsy and other interventional procedures. Then identification and biopsy data for abnormal adrenal lymph nodes. Then evaluation of problems associated with breast implants. Ultrasound also used to assess the breast implants, its complication like rupture. And as a supplement to mammography for screening of occult cancer in women who have heterogeneously or extremely dense breasts, who are determined to be at elevated risk of breast cancer or with newly suspected breast cancer, or who are not candidates for MRI or have no easy access to MRI. Actually, I have written this because these are what ACR guidelines have written, it's just entire statement. But in crux, this means that if you have a young individual with a high risk of breast cancer, or mammography it's going to be a dense breast, then in that case, you should use ultrasound as a complementary screening tool for the occult cancer, especially when she can't undergo MRI. And ultrasound guided intervention, you can do many interventions in ultrasound guidance like FNC, biopsy, DNA collection, or galactosine. Nowadays, we put marker placement before neoadjuvant chemotherapy, biolocalization, both therapeutic or diagnostic. And also nowadays, we even do ultrasound guided therapeutic web excision, especially fibroadenoma or small detector papilloma. Even ultrasound guided cryoablation and RFA of the different breast masses are being done. So we can do a wide range of intervention using the ultrasound guidance, both diagnostic and therapeutic. So to conclude, breast ultrasound is indispensable tool in breast imaging. Proper optimization of imaging parameter should be done to avoid misinterpretation of finding, and whoever doing breast ultrasound must be familiar with everything like how to just focus, how to just doctor setting it out, so that you don't give wrong reports. So thank you. Now I have 5 questions. So how do we do this? This is the first question. What scanning pattern is being used here? Anti-radial scanning, radial scanning, longitudinal scanning, or transverse scanning?
The answers can be put in the chat box.
You can go to the next question.
We have some responses, ma'am, for the first one. Shall we discuss the answers alongside?
Yeah, I will say only. So most of them are
Okay.
reply. A.
Yes.
No, this is not anti-radial. This is radial. Probe is with transverse. Over here, it's going like this. So this is radial. Anti-radial, when you probe will move from here to this side. This will be perpendicular to radial, anti-radial. So this is radial scanning. So when you move like this is radial scanning, and when you move from outer to inner like this is anti-radial scanning. So this is radial scanning. Second question, which type of CR wave is shown in the above image? Qualitative CR wave, 2D CR wave, point CR wave, strain CR wave.
So we have D as the answer. D.
D, yeah, correct. Strain CR wave are nowadays they are giving most of the machines. But the 2D CR wave, you need to take it separately. It's not free available with all the machines. But the strain CR wave is commonly available, so you can use this. You can check in your machine. So this is the image. The first question, which imaging technique is demonstrated in the image above?
First one is panoramic view.
Yeah, correct. This is panoramic view. What are the other methods to increase the field of view for measuring a large region? If you don't have panoramic view in your machine, what else you can do? What are the 2 methods that I have described?
I think you can revise the answers in the interest of time.
Anyone has replied in the region? So they tell them, sir.
You can explain in interest of time.
I have told you, like, when the region is large in size, you want to know the entire size of the region. And if you don't have this panoramic view, what you can use, you can split the screen into 2 parts. It is dual display, and you then take half the image in the one side and half on the other side without overlapping the image, and you can measure it. That is, you get a 2 static image of the part of the region, and you can measure it. It is dual screen display. Or you can use a trapezoidal method where your base becomes widened, so your region might fit in that. And the other third thing is, if you have ABS 3D ultrasound, then if you have the entire volume of breast, you can measure in the infrastructure images. Okay. Then the third question is, which type of probe was used to acquire the image above? These are the same probe that you are using for ultrasound of breast. The same probe is used, you need not have some additional probe. So same linear high frequency probe has been used. Now, which of the following ultrasound features most suggestive of metastatic involvement of an adrenal lymph node? This is a very easy one. So the way for answer is right.
Discuss the answers.
Normal lymph node will be oval or uniform in shape between cortex, between text, refractory hilum, and they will be homogeneous ecotexture. So eccentric cortical thickening more than 3 mm is suspicious in case of breast cancer patient, which I have already discussed in detail in the lecture. So the last question, the two-handed compression technique most commonly used in ultrasound imaging of the breast to evaluate lesions located in which region? For fibroma in the upper inner quadrant, agitated mobile, or axillary tail region, or retroviral region, inflammatory fold. Again, I have described 3 techniques for the evaluation of the retroviral region, and one of the technique was two-handed compression, where you compress the nipple between the transducer and your other hand, so that you can see the retroviral ducts nicely. Okay, thank you. That's all.
Thank you so much, ma'am. Ma'am, we just have one question from the attendees that why is the fat in the breast ultrasound isoechoic or lower in echogenicity compared to the breast parenchyma?
Why is the fat in the breast?
Iso or hypoechoic compared to the breast parenchyma?
Yeah, this question has been asked stressfully also, why the fat in the breast appears hypoechoic when the rest of the body appears echogenic. This is something related to the constitution of that breast physical properties. And in the breast, it is isoechoic to hypoechoic when the rest of the breast in the fat appears echogenic. And this was what answer was given to me also. It's just it's a composition of physical properties that it appears isoechoic in breast or hypoechoic in the breast when the rest of the body it appears echogenic.
Thank you so much, ma'am. I think that was a very comprehensive and a very coherent talk, and you have discussed all the aspects of breast ultrasound, the acquisition, the indications, and with multiple images also, with great detail. And that's like a small package for us, for anybody who's wanting to, do a breast ultrasound tomorrow. It was a great talk. Thank you so much, ma'am.
Thank you.
So we'll be starting with the next talk now, which is by Dr. Poonam Bajaj. Dr. Poonam Bajaj, she is the senior consultant and director at the Ultrasound Center, Gurgaon, and her talk will be on BI-RADS ultrasound. Ma'am, please, I invite you for the next talk.
Thank you, Dr. Malvika, and thank you, Dr. Tulika, for giving me the opportunity to be here. I do this every year for ICRI, and it's always a pleasure because it gives me a chance in my grey years to interact with the residents, and I hope that I will be able to put across some points via this lecture. Okay, so I'm going to start my screen share. Please tell me that you can see me as well as that you can see the it. 1 second. Okay. Can you see me?
Yes,
Yes,
ma'am.
visible.
Please put it in full screen mode.
Yeah, but you can see the slides, right?
Yes, ma'am.
Now can you see? I don't know whether you can. 1 minute, I think. 1 minute. Just give me a break. Just give me 1 second. Yes, please. I'm putting it on. Yeah, now it's all okay?
Yes, ma'am.
Okay. So as we all know, my topic for today is ultrasound BI-RADS. And I'll start by talking a little about this landmark study that was with Stavros, published in Radiology in 1995. And this really established ultrasound morphological criteria to differentiate benign from malignant solid lesions. And he gave features of benign nodules and listed features of malignant nodules, and then used this classification model to decide whether if they were fitting into benign features, they can be followed up. And if they were indeterminate or having features of a malignant nodule, then biopsy could be done for the lesions. And this was way back in 1995. And really, this study was the groundwork that was laid for the establishment or the introduction of the ultrasound BI-RADS lexicon, which was released by American College of Radiology 8 years later in 2003. And currently, we are following the 5th edition, which was released in 2013. Now, we know that the BI-RADS ultrasound contains a lexicon of descriptors that help us to analyze lesions and release a standardized report format that will effectively communicate a degree of suspicion to the referring clinician as well as to the pathologist if we were to do a biopsy for the lesion. So let's completely dive into the descriptors for feature analysis of the lesions. The first descriptor, and the way I remember it for the residents is, I remember some shape. So S for shape, O for orientation, M for margins, E for echogenicity, and P for posterior features. And we must remember always that if we see even 5 benign features, but we see 1 suspicious feature, that most suspicious feature will dictate the final BI-RADS that you assign to the lesion. And this must be communicated at the end of every ultrasound report for the breast. So let's start with the first descriptor, which is shape. Now, the shape can be oval or egg shape, as we see here. As of now, we include 2 to 3 gentle lobulations that you may see on the surface within the oval shape. Round means that the anterior-posterior and side-by-side diameter is more or less the same. We know what round is or ball shape, and anything which does not conform to oval or round is considered to be an irregular shape. The next is orientation. When we look at the lesion, we look at the long axis of the lesion, and then we see if that long axis is parallel to the skin surface. If it is said to be in parallel orientation, like we see here. If the long axis of the lesion is perpendicular to the skin surface, like we see here in all of these lesions, then we say that it is anti-parallel or not parallel orientation. Now we come to an important one, and that is margins. Margins can either be circumscribed or non-circumscribed. Once we say that the margins are non-circumscribed, we have to further categorize them. Let's see how we go about this. So the first is circumscribed. The English Webster Dictionary says that circumscribed means sharp, abrupt. So when you see sharp margins, like you see here, with an abrupt transition between the lesion boundary and the surrounding parenchyma, you say that the margins are circumscribed. Now, when the margins cannot be made out or they are not conforming to this abrupt transition, like we see in any of these cases, for example, this one, we just can't make out where the margin of the lesion is, then we have to further categorize and say whether they are indistinct, microlobulated, angular margins, or spiculated margins. Indistinct, as the name implies, means that we really can't make out the margins of the lesions. See the lateral sides, that will always give you a better idea. Microlobulated. Actually, this one is better seen along the anterior margins. What is microlobulated? It is not to be confused with lobulated. Micro means small and lobulated means bumps. So if you want to remember the two, remember that when you have a circumscribed margin, we've all grown up eating Marie biscuits. The circumscribed margin is one that you see with a Marie biscuit. And a microlobulated margin is one, if you imagine a Monaco biscuit. It has little bumps on the surface. If you see that, it's called microlobulated margins. Angular, best seen along the lateral or the anterior margins of the lesion, are margins which form acute angles. Can you see these coming out? These are acute angles that the lesion is forming with the surrounding parenchyma. And what about spiculated? We know what spiculated lesions look like on mammogram. Similarly, on an ultrasound, you look along the lateral margins for these fine alternating hypo and hyperechoic lines that you will see. These are spiculated margins. The next descriptor that we have is mass echogenicity. Anechoic, we know, clear contents, no echoes. This is what anechoic looks like. This is a duct ectasia. You can see a dilated duct. And as Dr. Upasana explained to you, you have to set the features of your machine right so that the knobs have to be worked on for each and every case so that the fat appears like a mid-level gray. If you have a lesion which matches the echogenicity of the surrounding normal fat, you say that it is isoechoic. If it is brighter, like you see here, or whiter than the surrounding fat, it is hyperechoic. If it is darker, we know what hypoechoic is. It's darker than the surrounding fat. And if it's a mix of these echogenicities all in one lesion, we say that the lesion has a heterogeneous echogenicity or echotexture. Another echogenicity or a descriptor that we must know of is when you see a predominantly cystic lesion with a vascular solid component like we see here, we call it complex cystic and solid echogenicity. The next descriptor is posterior features. What does it mean, posterior features? What is the effect of the mass posterior to it? What is the effect that it's causing posterior to it? You see this mass, there's nothing happening posterior to it. It's the same echogenicity as the surrounding parenchyma, and therefore we say this mass has no posterior features. If there is darkening or shadowing behind the mass, we say it's shadowing. If there is increased attenuation of the beam or whitening of the area behind a mass, we say there's enhancement. And if some parts of the mass shadow while others enhance, then it is known as a combined pattern of posterior features. And we must remember, contrary to what we learned, or at least my generation learned when we didn't know better, was that if you had something enhancing, it was meant to be a benign lesion, not anymore. Or each of these, see, if you look at them, they have more worrisome features than just enhancement. They have angular margins, they are irregular masses. Okay, so again, just to reiterate, and I'll keep reminding you, the most worrisome feature will dictate the final Beirat's assessment category. Now, once we have looked at the 5 descriptors, we now move on to looking for calcifications associated within the lesion or outside the lesion. We no longer measure calcifications or echogenic foci that we see in a lesion or around it. So we don't use the words microcalcification or macrocalcification. Instead, we say whether the calcifications are within the mass or outside the mass, or whether you can see intraductal calcifications. Let's look at some calcifications within a mass. This is a circumscribed mass, and you see coarse calcification causing shadowing. This was an involuting fibroadenoma. Again, you see some fine echogenicities within this mass, and this was a malignant lesion. But both will be described as, instead of micro or macro, you just say that calcifications are seen within the mass. And sometimes I like to use the word suspicious echogenic foci or suspicious calcifications are seen within a mass when I'm dealing with a mass like this. Then you look for calcifications outside the mass. What does that mean? This is a duct, abnormal duct, which is associated with a larger mass, which is not in the picture here. Okay, so these are abnormal ducts around the mass, and if you see, you'll see tiny echogenic foci within this, indicative of involvement of the duct. So outside of the mass, you must look at any calcifications that you see, especially within abnormal ducts associated with the mass. Intraductal calcifications with better equipment, like we saw in the previous lecture, we can actually see benign rounded secretory intraductal calcifications, like we see here, even in normal caliber ducts. After that, there is a category of associated features in the Beirat's atlas. Now let's go through each of these one by one, and these must be looked for as well as commented upon if they are present. So the first is architectural distortion. Now I understand that you know what architectural distortion looks like on a mammogram, but what does it look like on an ultrasound? For the longest time, I was confused. Basically, you have to see what is the effect of the mass lesion that you're seeing on the surrounding normal breast parenchyma. Like you see here, there is blurring of the margins with the normal breast parenchyma. And if you observe carefully, this is your anterior mammary fascia, and it's literally caving in towards the lesion. Okay, this is architectural distortion associated with this very abnormal suspicious lesion. Another case to explain the same. Now you see, this is the normal breast parenchyma, this is the lesion, and we really don't see a boundary. So it's blurring the boundary between the mass and the surrounding parenchyma. And once again, you see a little bit of focal incaving or concaving of the surrounding parenchyma towards the mass. This is what architectural distortion looks like on ultrasound. We also have, under the associated features category, we have the duct changes. Sometimes you have an abnormal mass and you see direct extension into the surrounding ducts. Can you see this? These are actual TDLUs or terminal ductal lobular units filled out with the tumor in the surrounding duct where the mass is extending towards the nipple. You should also look for changes in arborization pattern. You can see that there is focal multiple ducts which appear prominent along this malignant lesion. This is the case that we saw earlier also. And sometimes you'll see that ducts which appear a little normal, but look at their caliber. So there's a change in caliber or the arborization pattern in the surrounding ducts, and we must comment on this. Skin changes. Now, normal skin in the breast is not more than 2 mm except in the nipple areolar complex or in the inframammary fold. So anything more than that is taken to be skin thickening. What does parenchymal edema look like? You see these hypoechoic reticular pattern in the parenchyma. Can you see this? This is the reticular pattern in the parenchyma, and this is indicative of, like fluid clefts basically, is indicative of parenchymal edema. Another thing that we must have seen in the previous lecture is that the breast is held up by Cooper's ligaments. Okay, and what happens is that the tumors tend to extend along the Cooper's ligaments. And what does it do? Normal Cooper's ligaments are slanting. You'll see those white echogenic or echogenic lines, thin lines coming down, which are normal Cooper ligaments. But look at this. You see straightening as well as thickening of the Cooper's ligaments. This is the mass, and this is how the extension is happening towards the skin surface. So these are abnormal Cooper's ligaments. Nipple retraction. Especially like you see a mass here, it's right in the retroareolar region, and you see that the nipple has been pulled in posteriorly by this lesion. And we just saw how important it is to image this area. The nipple areolar area has to be imaged very, very carefully using all the maneuvers that you were spoken to about in the previous lecture by Dr. Upasana. And sometimes you can get a large mass, especially when women are shy to report that they are feeling a mass. The mass ulcerates out, and this is one of those cases where there's full thickness involvement of the skin by this abnormal or highly malignant mass. Vascularity is also under associated features. You look for vascularity within the mass, not peripheral vascularity. Within the mass, if you see vascularity, then it is said to be having vascularity. Otherwise, you just say that there is no vascularity. What is this? There is nothing inside the lesion, but there is a lot of rim vascularity and hyperemia. This is classical for a breast abscess, particularly the staphylococcal abscesses. Okay, now let's look at neovascularization or abnormal vascular patterns that you will see associated within malignant lesions. So this is a highly malignant looking lesion, and look at the vascularity. It's just very, very haphazard, indicative of neovascularization, which we know is the hallmark of malignant lesions. This is the case that I showed you. This was the abnormal ducts that we have been seeing in the last 2 or 3 slides. But when I put on color, see what's happening. There is so much abnormal vascularity around this area of increased ductal prominence that we see here. And if you notice, all these vascular signals are actually coming into the ducts. Okay, so they're going perpendicular in. They're not running along the ducts. Another case, and we'll see what non-mass is, but here is a non-mass lesion, and you see that there is focal increased abnormal vascularity that you see associated with this lesion. I'm sure Dr. Upasana has also told you about how to elicit vascular signals in the breast. Okay, so the pressure has to be very, very minimal. Elasticity assessment is a big topic all by itself, but needless to say that you cause a manual strain and you cause displacement of the tissue, and then you get a color coding depending on how the displacement is. So this is the classic that you see with a cyst, a trilaminar pattern, or you may get this typical mosaic pattern associated with a fibroadenoma. Contrast all these with this. Now blue here is hard. See how uniformly blue this very abnormal, malignant, irregular mass with angular margins is. Okay, so this is how we use elastography. It has been included in the BIRADS, but you cannot trump elastography findings and ignore the morphological findings. So the first comes the descriptors, and this is an add-on. Typically, I would say that this is used to upgrade from a 3 to a 4 rather than vice versa, at least in my practice. Okay, let's go to some special cases and let's just quickly see what they look like. Simple cyst, we all know, anechoic, thin, imperceptible walls, no vascularity. Clustered microcysts. This is a very common thing that you will find in the breast. What is a cluster of microcysts? When you see tiny cysts, all avascular, thin, imperceptible walls clubbed together. They're close to each other. Each of these cysts has a size of 1 to 3 millimeters or so, and there are no abnormal signals. You say that there is a cluster of microcysts. This is usually a benign finding, and we'll see what BIRADS 1 has to assign to this. A complicated cyst. A simple cyst is one where there are no echoes inside. If you see homogeneous low-level echoes within a cyst, it is said to be a complicated cyst. Axillary lymph nodes, a particularly abnormal-looking one, like we see here. We saw this in the previous section about the hilar-cortical relationship, and this is very definitely abnormal, are also included in special cases, as is an intramammary lymph node, the classic oval circumscribed lesion with an echogenic center and a hilar vascular pattern. Skin lesions are also included in special cases. These are some examples. The classic cysticercosis in the breast skin with the scolex there, a large epidermal inclusion cyst or sebaceous cyst in this lady who had a lot of pus coming out, a lot of inflammation. So this was an inflamed sebaceous cyst. Implants are also included in special cases. This is the classic stepladder pattern of an intracapsular rupture of an implant. Fat necrosis can closely mimic malignancies. Like you see here, if you look at this and you say, oh, parts are shadowing, parts are enhancing, it's irregular. What BIRADS should I give it? Well, the simple way to do it is you do a 1-view mammogram. If you see fat there, you can call it fat necrosis, give it a BIRADS 2 and move on. No biopsy is needed. So you have to work around cases and take the right clinical perspective into account. The clinical history is one of the most important, and as we'll see, we will go to that when we do revision cases. Vascular abnormalities. This was a 14-year-old kid who was just copiously draining blood through her nipple, and the minute you put the probe there, you'll see that there is this venous malformation that was responsible for that symptom. Now, once we've looked at the main descriptors, we've looked at the associated features. We've seen whether there are some special cases that it fits into where we just give a direct BIRADS and nothing else is needed. We now come to assigning the assessment categories or giving the final BIRADS assessment category at the bottom of every report that you see. If there is an ultrasound being done along with a mammogram, they both have to be reported together, and the higher BIRADS will be finally assigned to the lady. So coming to that, let's go to BIRADS 1. It means it's negative. We see no abnormality on ultrasound. Like I said, assign mammogram category if it's higher. And if both are negative, it's always worthwhile to put a little disclaimer on your report saying that a palpable abnormality should be managed basis degree of the clinical concern. BIRADS 2 means that there is zero likelihood of malignancy. There is no chance that these lesions can be malignant or in future be malignant. And let's see some examples of this. The first is a simple cyst. We already saw what that looks like. Implants are also BIRADS 2. A stable fibroadenoma which has been downgraded after looking at it for 2 years from the time of detection at first detection, and then you downgrade it if there is no significant increase in size, then it's a BIRADS 2. A hamartoma, circumscribed lesion with an echogenic capsule, echogenic, internal or heterogeneous, predominantly echogenic is an hamartoma. It's a BIRADS 2, does not need to be followed up. Galactoseals in the appropriate setting are also BIRADS 2. A shift in the fat fluid level, like you see here in this case, I turned the patient around for 20 minutes and see what has happened. So this is not an abnormal, complex, cystic and solid lesion. Okay, you have to use power Doppler, everything that you have. You use power Doppler, there's no vascularity here, this is the color box. Okay, then you turn the patient and see if there's layering. Obviously, it's not a solid component inside a cyst. Intramammary lymph nodes are also BIRADS 2, as are post-operative changes. You see a small oil cyst here, typically after breast conservation surgery, it is seen, and these are all BIRADS 2. Now, a lot of times, a woman or a girl comes with one palpable abnormality. So she can feel one lump, but once you start doing the ultrasound, you see, oh my God, there are lesions in both breasts. All of them are circumscribed, they're oval, okay, they're hypoechoic, and basically all of them look the same, both in both breasts. So what do you do next? Do you biopsy each of these lesions, or how do you choose what to biopsy? Or more importantly, do you really need to biopsy these? Okay, if there are more than 3 similar lesions in both breasts, which obviously means that you have 2 or more in one breast and at least 1 in the other breast, you can give it a BIRADS 2, provided they all look the same. You don't need to follow up these lesions. BI-RADS 3 is that these are probably benign lesions and there is a very low likelihood of malignancy of up to only about 2%. What is included in this? If you get an oval circumscribed mass with this thin echogenic capsule that you're seeing, we know that's like the pseudocapsule associated with a fibroadenoma, and this lesion is in parallel orientation, we say that this is a probably benign lesion and we can put it on a follow-up if it is the only lesion that you are seeing and this is the palpable concern. However, during the period of follow-up, which we are going to do at 6 months, 12 months, we can skip 18 months if there's no change and move on to 24 months. So we've done at least 3 follow-ups for this lesion and there is no change. We can downgrade this to a BI-RADS 2. However, if there is more than a 20% increase in the longest dimension of the lesion during follow-up, it becomes a BI-RADS 4 and you have to biopsy this lesion even if it looks benign on ultrasound. Included under BI-RADS 3 are also isolated complicated cysts. So we saw complicated cysts. If there are multiple cysts in the breast and you see one with low level echoes, you can ignore it and put them all as BI-RADS 2. However, if this is the only lesion that you see in a breast and there are low level echoes, you must follow it up. Likewise, for a cluster of microcysts, if this is one of many in the breast, you can ignore it, but otherwise it has to be followed up at 6, 12 and then 24 months interval. Now, quick word about intraductal papilloma, very commonly seen, or I would say rather commonly seen. Now, this was an asymptomatic lady. She had a mammogram and she came for a correlative screening ultrasound. And this is what I saw. There was a prominent dilated duct and you see an echogenic lesion inside this duct and there was a single vessel feeding this. But see the echogenic lesion, it's not going outside the duct boundary. It is not filling up the entire duct. Okay. And this lady was asymptomatic. If all these conditions are met, you can do a 6-month follow-up and give it a BI-RADS 3. All right. If, however, the same lady was symptomatic and I saw this or I saw this, if she was symptomatic, I have to go ahead and do a biopsy. This is a central papilloma just in the duct at the near the nipple. This is in the nipple areolar complex and you see this echogenic lesion and you see a single vessel feeding it. Okay. So these, because the lady is symptomatic, we have to biopsy it. There is a small but certain chance of an upgrade. Okay. So it may turn out to be a benign papilloma, but there may be some focus of atypia or DCIS, ductal carcinoma in situ associated with the papilloma, especially if the patient is symptomatic. Okay. So that's how we give a BI-RADS to papillomas. Also, even if the lady is asymptomatic. Okay. Let's take this. But this is the picture that we are getting. We did a screening ultrasound and we see this echogenic area. It's going beyond the duct boundary. It's protruding out. There are abnormal vascular signals that you see here. Can you see this? So if that is the case where this lesion is extending beyond the duct walls or filling it in completely, it is a BI-RADS 4 because this is suspicious, even if the lady is asymptomatic. Now, coming to BI-RADS 4, it is recommended that you subdivide it into 4A, 4B, and 4C. Okay, and there are some percentages given. Now, it's very difficult to see a lesion and say, is this 10%? Is this 50%? Is this looking between 10 and 50? Extremely difficult. Then why give these 4A, 4B, 4C? The reason or the reasoning behind this is you need to convey to the pathologist and the clinician the degree of suspicion that you have with a particular lesion. And with time, as you practice breast ultrasound, you will understand what to give it. Okay, so if you have a 4A, a benign pathology will be considered concordant once you have biopsied the lesion. Now, for all of BI-RADS 4, you have to carry out a biopsy. Okay, if the lesion result comes back as benign and you've given it a 4A, it's considered concordant with pathology. So there is radiology pathology concordance. That is what has to be established by giving this 4A, 4B, 4C. 4B, where there's moderate suspicion, but both benign as well as malignant are considered concordant. However, if you give a lesion 4C and you have a high suspicion, more than 50% likelihood of a malignancy, and you get back a benign pathology result, it is considered discordant, and these lesions have to be further managed. So you don't send the patient home with a benign report. You say that there's radiology pathology discordance. Either you will rebiopsy, or as we saw in the previous lecture, you may go ahead with vacuum-assisted breast biopsy, or sometimes even a surgical excisional biopsy if the suspicion level is high and the initial biopsy has come out as benign. So let's see some examples. Now, this is a circumscribed lesion. We saw something similar, right? You have an echogenic capsule. It is slightly heterogeneous, but this could pass off as a benign lesion. Then why did I biopsy it? Because clinical history is very important. This lady reported that she's had this lump, but it is growing now. So if the lady reports that it's growing, we have to biopsy it. And this came back as FASH or pseudoangiomatous stromal hyperplasia, which is a benign condition. And therefore, it was concordant. Another case, circumscribed lesion, but it has a heterogeneous echotexture, cystic areas within, okay? And we thought it was a fibroadenoma, but we were not sure given these cystic areas, okay? It wasn't that classic hypoechoic fibroadenoma. It was biopsied and it turned out to be a fibroadenoma 4A concordant. Now, this is a lesion with few fluid clefts. Can you see these anechoic areas? And you see a lot of vascularity within this lesion, okay? This is a classic appearance for a Phyllodes tumor, but you need to biopsy these given this appearance, and this came back as a benign Phyllodes. It could have come back as malignant Phyllodes also, but this was looking very, very circumscribed. This was the case we saw. This lady was symptomatic, and that was the reason for biopsy. It came back as a benign papilloma with no atypia or DCIS. It could have also had a focus of DCIS. That meant that 4B meant that both benign as well as malignant are concordant. Let's look at this. You saw this earlier. It's an irregular mass, echogenic foci within. It's got spiculated margins, angular margins. There's architectural distortion, all malignant worrisome features. If you biopsy this, this comes back as benign. It is discordant, and further action has to be taken. Likewise for this lesion, it's an irregular mass in anti-parallel orientation, and there is duct extension. Another one, we saw this hypoechoic microlobulated architectural distortion, 4C, again high likelihood of malignancy. Now, as we go and we see more and more of ultrasound and mammogram, I just want to put this case forward to show that there are outliers in every group. Okay, there are cases which you need to know that, oh, this is what it looks like, so this is concordant. Now, on 2D, there was subtle asymmetry like you see here, okay, in the upper quadrant. On 3D or TOMO, you see that there is a spiculated mass with architectural distortion, and this is the correlative ultrasound that you have done. And what do you see here? You see a hypoechoic mass with microlobulated and spiculated margins, irregular mass in anti-parallel orientation, highly suspicious. So what would you give it? You'd give it a 4C. Both mammo and ultrasound are highly suspicious. And what did the biopsy come back? It came back as a radial scar with a papilloma. Now, will you say that this is discordant and that further action and that we should go and go ahead and do an excisional surgical excision for this, an excisional biopsy? No, because we know, and in our minds, we have certain pictures, radial scar, diabetic mastopathy, a lot of dense fibrosis. These are what those lesions are going to look like. We will give it a 4C, but when it comes back, you can accept it as a concordant result and just do a benign biopsy follow-up, which we do for every lesion that we biopsy. Even if we get a benign biopsy result, we still follow it up at 6 months, at least once the same lesion. Okay. BIRADS 5, that's out and out malignancy. Where I trained at Memorial in New York, we would never give up BIRADS 5. We would just say 4C. And that was because 4 means please biopsy. So it shouldn't get missed, thinking nobody said biopsy recommendation because that's with 4. So this you can put in as a 4C or you can put in as a classic 5 where there's more than 95% likelihood of malignancy. If you get a benign biopsy result, it is considered absolutely discordant. BIRADS 6 is when there's a known malignancy and it's prior to initiation of neoadjuvant therapy. You have a large mass here, it's biopsy-proven carcinoma. You will like to put a clip here, you like to measure the mass at follow-up ultrasound, and after neoadjuvant chemotherapy, a lot of times these just melt away. You don't see them again, okay? And that clip will then guide you. You can do a wire localization of that clip and help your surgeon dissect around that region for breast conservation, okay? So this is how we work in breast imaging. Now, the new update, which is expected, Dr. Upasana also mentioned, is likely to come out next year, which will be the next edition. Now, one of the changes which might come about is in the descriptor shape. So we said if we see 2 to 3 gentle lobulations, we call it oval, but in the next BIRADS, most likely under shape, this is not the margin, under shape, you may get an introduction of a new shape called lobulated. So if there is absolutely smooth margins, no bumps, then you would just call it oval. But if you see these gentle lobulations like you see here, then this will qualify as lobulated. And the reasoning is that they feel that there's a slightly higher probability of a malignancy in lesions which have lobulation. So lobulated under shape might be introduced, not to be confused with microlobulated under margins non-circumscribed. Okay, next. The next thing that we may get in the, can you just tell me, Dr. Malvika, how much time do I have left?
Ma'am, we still have about 15 minutes, ma'am. 10-15 minutes.
Okay, so I'll quickly go through this because I'd really like to go through the
Right,
case.
ma'am.
Okay,
Right.
all right. So in the next BIRAD may be introduced is echogenic rind. Now, what is an echogenic rind? Now, it's a thick band of echogenic tissue that you see surrounding a very obviously malignant appearing lesion. Okay, and the main hallmark of this malignant or associated with malignancy echogenic rind is that you will have a variable thickness. It's non-uniform. It's very thick. Some parts are thicker, some parts are less thick, but there will be a very variable thickness and it will be thick. When you see this, it likely represents a desmoplastic reaction or peritumoral edema and has a high positive predictive value for this lesion being a malignant lesion. Okay. What do you have to differentiate it from? You have to differentiate it from this smooth echogenic pseudocapsule that you see associated with circumscribed masses or fibroadenomas. Okay, can you see this? This is very thin and echogenic. This is thick. It's got a variable echogenicity and it has a variable thickness like you see here. Okay, now how do you report the echogenic rind? You say that there's an echogenic rind associated. Either you can measure the mass separately like we've been doing and give the thickest part of the echogenic rind, the thickness separately when you mention the echogenic rind, or you can include the echogenic rind in the measurement or the primary measurement of your mass. Now, also associated next BIRADS is something which actually we've been using for a long time. We just use some descriptor for it. Now, very often when you do breast ultrasound, and especially when you're trying to correlate doing a second look ultrasound after a mammo, especially when it's showing architectural distortion or asymmetry, okay, or you're doing a second look ultrasound after an MRI, which shows a non-mass enhancement, okay, you see abnormalities that do not rise to the criteria of a mass. A mass has a definable shape. It will have a margin that you will be able to assess, okay? But what about if you don't have it? Then you say that this is a non-mass lesion. Okay, so you won't comment on the shape or the margin amongst the descriptors because by definition these are not supposed to be there. If they were, you would call it a mass. Okay, but you can comment on the echogenicity, whether it's hypo, iso, hyper, or mixed echogenicity. Like MRI, you can talk about the distribution. So you can say whether it's regional, that non-mass that you're seeing, is it focal, is it linear? Okay, is it like a ductal pattern going towards the nipple, or is it segmental? Very, very similar to MRI. I'm not going into the details. And you can sometimes talk about whether it's parallel or anti-parallel, just the way you do for the mass lesions. Now, when you see something which is not fitting into a mass, look for associated imaging variables on ultrasound. See whether you can see any echogenic rind. Is there some kind of echogenicity around that area? Is there architectural distortion? What's happening to the surrounding parenchyma? If you remember what we said for architectural distortion, is there some shadowing? Is there hypovascularity, ductal extension, abnormal duct changes along it? Are there any echogenic foci which could suggest malignancy? If you see something which is just like small cysts, what a lot of people report as fibroadenosis, and I don't, because I don't believe that that term deserves to be on an ultrasound report. Yeah, if you see small cysts, it is suggestive of a benign non-mass lesion. Okay. Also look for associated clinical variables. Now, you're only doing an ultrasound, you don't have an MRI, you don't have a mammo, but the lady complains of nipple discharge or a palpable lesion, okay, your antennae will be up. So you will think your suspicion level will be increased. You also look for imaging correlation. Like I said, if you see architectural distortion on asymmetry on mammography, and you're doing this as a targeted second look ultrasound, and you see something like this, it is highly suspicious. Same as if you see abnormal enhancement at contrast enhanced mammography or contrast MRI. So let's look at one such example. Here you see, so this was a palpable abnormality reported by the patient. Here you see that there is a hypoechoic area. It's not fitting into a mass. It doesn't have margins. It doesn't have a shape. But when you look closely and you look for associated findings, you'll see these tiny echogenic foci likely to be calcifications within this non-mass. Okay. And when you put on power Doppler, you see that there's focal increased vascularity in this area. So this is suspicious non-mass and you will give it a 4B at least or a 4C. Okay. Anybody who wants to read more about non-mass lesions this is a very good article by Vatanen and it's been released in 2021. So that's the reference for this non-mass on ultrasound. Also, in the overview, we have in the next update, we have an expansion of discussion on lymph nodes. I'm not going into this. This was covered in the previous lecture. So let's quickly move on. So we have to talk about the levels of axillary nodes. We also have to look for internal mammary nodes, supraclavicular nodes, and we have to definitely mention morphology, especially the cortical-hilar relationship. Normal hilar vasculature, normal cortex, no cortex at all. It's completely, no hilum at all. It's completely obliterated. And look at the vascularity. No hilar vascular pattern, abnormal vascularity coming in from the periphery to the center of the node. So now that we have looked at everything, let's quickly go through revision cases. Mr. Sebastian, do we have voting or should I just do it myself?
I'm having the voting option.
Oh, great. So this is going to be fun. We're going to go through 5 cases. It's going to take about 3 minutes a case, but let's try and do it fast. Okay. So case 1, look at the history. Let's listen to this. No, wait. I want to do this. Don't put this right now, please. Yeah. So this is a 40-year-old lady who came from Africa for infertility treatment. She had a screening mammogram in Africa, but she did not have any report. And she did not mention this to the IVF expert. She came for a short while and she wanted to just get pregnant. She was referred for a breast ultrasound after 2 IVF cycles, failed IVF cycles, for palpable nodularity that she reported in the left upper outer quadrant. So now she could feel something. So before the 3rd IVF cycle, the gynecologist said, please go and get an ultrasound done. When she came to me, she told me she doesn't remember what's on the mammogram, but they said some calcium was there on mammogram. All right. And she said that they said that we need to do something further, but she had a flight booked. And so she came back. She did not wait to get anything further done and therefore did not mention it to the gynecologist. The most important history that you must take is family history. There was a history of breast cancer in her elder sister, so 1st degree relative, at the young age of 37 years. So it was detected at 37 years. Okay. Now, beneath the palpable abnormality that she reported, this is what we saw. So look at these images very, very, very carefully. And the questions are coming up, or maybe I can flash them and then you can vote for this. So is this normal parenchyma? BI-RADS 1. Choice 2 is this duct ectasia? BI-RADS 2. Is this a probably benign mass lesion like a fibroadenoma? BI-RADS 3, which we want to follow up at 6-month interval. Is this a suspicious mass? BI-RADS 4C. And the 5th option is this suspicious non-mass? BI-RADS 4C. So please start the voting or the polling. We'll give you just exactly 10 seconds. The images are on the screen. I hope you can see the screen also. Are the other delegates able to see the pictures?
Yes, ma'am.
Okay, great. So they can see my slide also. Okay. Okay, are we done?
Ma'am, we have received few answers. Like 75% of them answer option 5 and 25% of them answer option 4, ma'am.
Option 4. Okay, great. Thank you. We can take this off. All right, let's look at the answers. Okay, 75% of you got it absolutely correct. Okay, let's go through what we have here. Okay, so the first is normal parenchyma. The answer is no. Why will I mark out something? That was the indicator. Okay, there's palpable abnormality and I've put arrowheads there. So obviously it's not normal parenchyma. Okay, now why is it not BI-RADS 2 duct ectasia? Because when you see it along the duct, look at the duct walls. They are so irregular. Duct ectasia will be very smooth walls. Anechoic contents. Here we see heterogeneous, absolutely, right? Hypoechoic areas here. Okay, so this is not benign duct ectasia. Next, is this a probably benign lesion? BI-RADS 3, fibroadenoma? Well, if you see only this, okay, that is where we go wrong. Like Dr. Pasna said, in 2 orthogonal planes. You always have to scan in 2 orthogonal planes. So this was one plane, but the minute you rotate the probe, you see that it elongates. Okay, and elongation means that if you're still seeing something, it's in ductal distribution. All right, it's not a mass lesion, firstly. All right, it is not a mass lesion, and you never scan only in one plane. With only one view, you would have probably called it a mass, even though even this does not have a shape and it doesn't have circumscribed margins. Can you see any margins here? No, you can't see any margins. Okay, so it's not a mass, and that's why the 25% who said that it's a suspicious mass are incorrect, because there is no mass here. There is nothing with a definable shape or there's nothing with a definable margin. So this is what a classic non-mass looks like. Now let's see why we gave it a 4C. Okay, this is the pictures again, and let's start describing it. So I'm going to quickly do it. I'm not putting it to voting now. How would you describe this lesion? You have to use all the descriptors that you possibly can. So the first is this mass or non-mass? It's non-mass. Second, what is the echogenicity? I said even for non-mass lesions, you have to talk about echogenicity. It is hypoechoic. It is in a linear distribution. It's elongating. It's going towards the nipple. And you see tiny echogenic foci here, okay, which is indicative of calcifications within this non-mass. And vascularity or abnormal vascularity, focal vascularity is present. Okay, and this was biopsied. It was given a BI-RADS 4C, and it came out to be a high-grade DCIS. And so remember this picture. This is most likely what DCIS will look like. Okay, with these tiny echogenicities in ductal distribution, very irregular areas of the ducts. The duct walls are looking very irregular, not conforming to a shape. So this is one of the common ways in which you will see ductal carcinoma in situ. Okay, case 2. This is a 20-year-old. She's 12 weeks pregnant. She's gravida 2, para 1. Okay, you have to remember that. She complains of a lumpy feel in the right breast. She doesn't have any pain. She had an ultrasound 2 years ago. This is a classic history that you will get with 90% of the patients that you will see in this country. 2 years ago for a lump. It was reported as benign by some sonologist as per the patient, and therefore she didn't do anything about it. Now, recent clinical exam done by a obstetrician reports that there is a right breast is generally enlarged and it feels hard. So they can't really make out whether there's a discrete lump. It's just like a hardness of the breast, and that is what she has been referred for. Okay, so here are your images. I put multiple images. Look at each one of them, and this is your poll. Okay, is there a way that we can move this poll to the side? You can
Yes,
see
ma'am.
over my written. Over my written. Is there a way? No.
Yes, ma'am. You have, ma'am. You can just hold like, and we can just scroll right side, ma'am. Right or left side.
So the delegates can do it.
Yes, ma'am.
Okay, I'm not managing to do it, but that's okay. So they can just move it to the side, and these are your options. One is it normal parenchyma in pregnancy? She's 12 weeks pregnant, remember. Or is it idiopathic granulomatous mastitis with reactive lymph nodes? She's gravida 2. Last childbirth 3 years ago. And after that is when she noticed the lump and she went for the first ultrasound. The third is a giant fibroadenoma with associated inflammation. And the fourth is highly suspicious malignant lesion with abnormal axillary lymph nodes.
Now we have received few answers, like 67% of them answer option 2 and 33% of them answer option 4, ma'am.
Okay, great. Thank you. I'll go down to, yeah, you can take this away. Yeah. Okay, so let's see why we are correct or not correct. Okay, normal parenchyma in pregnancy, no. This is a hypoechoic area. These are not normal ducts. And just remember that even if you are confused, you will not get any changes in the breast parenchyma before the second trimester. Okay, the breast looks absolutely normal in first trimester of pregnancy. It looks the same as it would in a normal breast. But this is definitely abnormal. I'm glad nobody said, normal parenchyma. Now comes the reason for the giant fibroadenoma. I'll first deal with that. Okay, firstly, fibroadenoma or a giant fibroadenoma, you would expect a circumscribed lesion. Here you have non-circumscribed margins and you have fine echogenicities inside this. Can you see that? So those are, even if you get two factors which are going against it, it is not number 3. Now, some of you have said idiopathic granulomatous mastitis. That was a really, really good bet. Okay. And the reason for that is idiopathic mastitis, granulomatous mastitis, IgM can very closely mimic a malignant lesion. Very, very closely. But what is the pointer here that it is unlikely to be granulomatous mastitis? In fact, sometimes you do an MRI also, and even then they look exactly like malignant lesions. And also on mammograms. Can you see these echogenic foci? Very rare to get calcifications in IgM. Okay, rare. That is one. And secondly, with IgM, you would not expect these. I wrote level 2 there so that you would understand that these are nodes. There are multiple rounded or irregular nodes with an abnormal vascular pattern. Can you see that? There's loss of the hilum completely. Okay, so this is not granulomatous mastitis, and that is where we went wrong. Yes, absolutely, you're correct. The 67% highly suspicious malignant lesion with abnormal axillary lymph nodes. Now let's quickly go through how you would describe this. I'm only going to speak so that we finish this fast. Now, what is the shape of this that you're seeing? It's irregular. It is in parallel orientation, long axis along skin surface. So parallel orientation, margins non-circumscribed. Okay, there's no abrupt transition. How will you describe these margins? They are indistinct and partly angular. Can you see these little angles coming out? These are partly angular. In fact, I would say some of them are even microlobulated. So it's a very mixed kind of a margin. Echogenicity, hypoechoic. There is posterior shadowing, like you see here. Okay, there is internal vascularity present in a haphazard pattern. So you'll say yes, there's internal vascularity. Calcifications are seen within the mass, like you see here. There's associated architectural distortion. You see the caving in. Okay, you see the caving in of the surrounding parenchyma, and there's blurring of the surrounding parenchyma, the boundary. There's skin thickening. Can you see this? Look at the skin here. And there's edema. Can you see these tiny reticular hypoechoic areas? That is parenchymal edema, these little fluid clefts that you're seeing there. Okay. And there's Cooper's. We saw this in the lecture. There's Cooper's ligament straightening and thickening, like you see here. And there were level 1 and level 2 nodes. Remember, breast hardly ever has skip metastasis. So level 2 dikhega, so you will always see level 1 also. So look for them. And there's level 1 and level 2 highly abnormal nodes, like I described just now, with loss of echogenic hilum and abnormal vascularity. That will complete your entire report. You have to mention each of these. Okay. And then say that it is a BIRADS 4C or a 5, nothing less than that. If you get back a benign biopsy, it will be considered discordant. Okay. All right, now these are easier. We're just revising descriptors here. We're not going through. So how will you describe this lesion? You have 3 options. Could we please have those on the screen? And you can move the box onto the side. And then this is case 3, Mr. Sudarshan. So just very quickly, very commonly seen lesion. How would you describe it? Which of these 3 options aptly or correctly describes this lesion? You can move the box to the side so that you'll see the lesion, please, delegates. Okay, do we have answers?
Ma'am, not yet, ma'am. Ma'am, we have received one answer. It's option 3, ma'am.
Okay, that's it. Everybody else left. They went home. Are there any participants, or the participants have left? I can't see that bar right now.
Ma'am, we are having participants.
Okay, then nobody's polling. Okay, let's go then. That's only 1 person reported. Come on, let's vote so we can all go home and have nice dinner. It's 15th August. I think let's get down to this thing. Please remove this. We're going to the next slide and I will discuss it. Okay. Okay. Now, so what did that 1 person report? 3, is it? Yeah, the one who took the trouble of saying it, you were absolutely correct. Okay. And it is an oval, circumscribed, hypoechoic mass in parallel orientation without posterior features or calcification. So you have to use all the possible descriptors. Why is the first one not okay? Because we use the word irregular. It's not irregular. It's an oval shape. Okay. And in future, there is a gentle lobulation. So we get the next update on the BIRADS. It's going to be called a lobulated shape. But right now, we still call it oval. The second one is not okay because this is hypoechoic. It's not heterogeneous. So that was the key trick that was there. Everything else fitted in except for the echogenicity. So it is what it is. The number 3 was the correct option. Case number 4, again, quickly tell us which one of these descriptors will fit into it. Each descriptor, starting with shape, orientation, margins, echogenicity, and posterior features. Some place. Shape, orientation, margins, echogenicity, posterior features. Are we getting anybody sharing in, Mr. Sudarshan, or should we just go to it? Oh, we passed time. Okay. Okay, let's go down. Are there any responses? Mr. Sudarshan, did we get anything? Okay, I'm going to the next one. Sorry, my bad. Please remove this. You can stop screen sharing, please, Mr. Sudarshan. Hello. Did we lose everybody? Can you hear me?
Yeah, ma'am, you're audible. I think.
Yeah. So can you just stop sharing so that this goes off and I can just go through the options?
It's
Okay.
not.
Yeah.
it's off.
Yeah.
Ma'am,
No,
I
I
get the
can
point,
see it was on. Okay. So any votes that we got? No.
No, ma'am.
Okay. So we'll quickly describe it. Okay. This is, what is the shape? It's irregular. It's hypoechoic. non-circumscribed angular margins. Can you see these angles coming out? That one, that one, that one, that one. So angular margins seen in anti-parallel. So this is the long axis, that's the skin surface. In anti-parallel orientation, no posterior features. Associated duct changes. You can see the extension of the tumor into the adjacent duct are observed. And that is the correct answer. It is not circumscribed, and that's why option 1 was not correct, and it is not in parallel orientation. So this is anti-parallel orientation. Okay, now this is the last one. And let's see this. We saw this, but let's quickly do it. I think don't vote. I'll just go to the next one, and we just go through the descriptors, and that is the last one. So how will you describe this? I don't think anybody wants to vote, so I think you can take it away. It's too much to read and get, quickly. I understand that. Maybe that wasn't a good thought to put it like this. Anyway, the answer is, so first we start. How do we describe? Look at the shape. Shape is irregular, not oval, not round. Okay, it's irregular. It's got microlobulated margins. Can you see the bumps? Monaco biscuit. Okay, microlobulated margins. It's heterogeneous. Some areas are showing cystic areas, some are echogenic, some are hypoechoic. It's in parallel orientation, long axis, skin surface. And it shows a combined pattern of posterior shadowing. Some parts are shadowing, some parts are enhancing behind the mass or posterior to it. It shows a rim pattern of vascularity. This is called a rim pattern. Can you see this? There's rim here, okay, of internal vascularity. It is devoid of internal calcification, and there is architectural distortion. Okay, you see a little blurring here, but there is no duct change that you can see, at least on this image. You'll obviously scan further and see, but you can't see it. And if I were to add with the next update on the bilaterals, you will see an echogenic rind. Can you see this echogenic area around it? This is the echogenic rind, and that is the correct way to describe this lesion. So with that, my take-home message. Please use all descriptors while reporting. Then associated features, talk about calcification, okay, and always look out for the most worrisome feature, and that will dictate the final BIRADS. And always, if you send a lesion to biopsy, you have to look for the result. You have to tell the pathologist to communicate it to you, and you have to establish RAD, path, or radiology pathology concordance for every biopsy that we do. It's the duty of the radiologist as much as it is of the clinician. Thank you for your kind attention.
Thank you so much, ma'am. It was an excellent lecture, and I really love the
I'm
images.
so sorry for this. I just realized.
I really love the images, and I think they were so explanatory with really detailed explanations of all the descriptors. And great. So, ma'am, I think we have just 2 questions. That what do we do further in BIRADS 3? Do we do an FNAC or follow-up?
No, BIRADS 3 as a category means you're following up. You will follow up that lesion. So either you have an oval circumscribed lesion, or you have an isolated cluster of microcysts, or you have a complicated cyst, or you have a papilloma in a symptomatic woman, okay, or asymptomatic woman, and it's not looking suspicious, that papilloma, intraductal papilloma. Then these are the 4 or 5 conditions you can put for follow-up. You follow up at 6 months, 12 months, no change. You can skip 18 and go to 24. Only after 24 months, when there is no change, no significant change. By significant, I mean more than 20% increase in size of the lesion over 2 years, you can downgrade it to a BIRADS 2. Any increase in size goes to BIRADS 4. Okay, yeah.
When do we ask for an FNAC in a breast lesion? That's another question.
We never do an FNAC, please. Okay, FNAC is redundant. FNAC is to be done when we have absolutely peripheral centers, and you need something. You need a proof that a lesion is looking malignant. Okay, otherwise the standard of care now is a core biopsy or a true cut biopsy. Okay, we never do FNAC. Please do not advise FNAC in your reports. If it is a BIRADS 4, under that write core biopsy or true cut biopsy is requested or recommended. Please write that word so that we don't have people going and getting FNAs done. All right. Neither do they tell us about fibroepithelial lesions, and neither do they tell us about malignancy. You can't do any markers on those. Nothing can happen with the FNAC sample. Okay, so please avoid. Thank you.
Thank you so much, ma'am. Dr. Tulika, ma'am, any words, please?
Yeah, first of all, I thank you all, Dr. Poonam, Dr. Pasna, and Malvika, for taking out time on a holiday for this session. And both the talks was very, very good and illustrative at the point of the resident teaching. So I hope they have benefited for this. And even I enjoyed both the talks. So not taking much of time, we can conclude this meeting and having our dinner.
Yes. Happy Independence Day to everybody. Jai Hind.
Jai Hind.
Jai Hind. Okay. Thank you all. Bye.
And thank you so much, ma'am.
Thank you, ma'am.
Thank you, Mr. Sarjan. You've been really, really kind, and very patient with me. Thank you.
Yeah, okay. Good night, everyone.
Bye. Good night.
Thank you, ma'am. I'm closing the session, ma'am. On behalf of the organizers, we thank you.
We can close the meeting.
Yes, ma'am. Thank you, ma'am. Ma'am, you have only a few seconds left. I'll start the session.
So good evening all. Welcome to yet another session of breast imaging in ICRA Radiology Resident Teaching Program 2025. So before starting the session, I am sending you a good wishes for Independence Day. So today